All right. Welcome to our weekly Wednesday presentation. Today we're joined by Kelly McGraw with HELIOS Care to talk about palliative care. The weekly Wednesday presentations are brought to you by Otsego County, New York Connects, who falls under the umbrella of the Office for the Aging. New York Connects can help anyone of any age navigate the complex long term care systems to remain as independent as possible in their homes for as long as possible. Today's presentation is being recorded. We ask that everyone except the presenter turn your cameras off and remain muted. You can type your questions into the chat, or because it's a small group, as I said, you can just unmute yourself throughout the presentation today. And again, I'll ask for any questions also at the end. So now I'm going to turn this over to Kelly.
All right. Thanks, Alicia. So yes, please do. I would encourage you to, if you have any questions, please feel free to ask them along the way. In a way, it's kind of helpful for me because it reminds me that there really are people there on the other side of the screen. It just feels more natural to me, more conversational, because I love to talk about what we do, the services that we are able to provide to people in the community who need the additional support in the home. My role with HELIOS Care is I'm the Director of Access, which means I work with a fantastic team of nurses who do all of the intake. They handle all of the referrals, help determine, with the help of the providers in the community, with patients and their families, which one of our programs they might need the most or fit into the best based on their needs. And so it's doing a lot of what we're going to be doing today, you know, really communicating, educating folks on what services are available to them, helping them to understand the differences between hospice and palliative care, talking about what both of those programs are as much as what they aren't. So again, feel free to ask questions along the way. I really want to walk away hoping that you got a lot out of this. I know many of you have been working in the field for a long time. Hello, Jennifer. I see you on the call. I may be preaching to the choir. We've worked on and off together throughout the years. I'm sure she's familiar with our program. So like I said, my challenge for this afternoon is going to be that hopefully you'll learn something new. Okay. I have to admit, it took me a while, a long time before, while working at hospice, before I really fully understood the differences between hospice and palliative care. And for some reason, okay, here we go. Because I couldn't understand when we talk about palliative care, and I think most people in the community struggle with it at first, understanding what palliative care is. And the best way I can describe it is, when you think of the word palliative, to palliate means to tend to. So that's what palliative care is. We're tending to patients' comfort, to their needs, helping them to manage their symptoms, tending to their needs to promote their comfort. And you would think this would be a no-brainer when you're talking about healthcare or in the medical field, but a lot of times, when we're working in the medical field, they're focused on diagnosing, treating, the disease itself, but not really maybe focused as much on the whole person, including the patient and the family, by treating all symptoms, not just the physical, but also the other things that can interfere with a patient's comfort when they're dealing with a serious illness, including, maybe the emotional distress, the psychological, the spiritual, the financial, all the things that come into play when you're dealing with a serious illness. And so this here is our mission, and you can kind of see from this statement that that's what we try to do, is make life easier, not only for patients and their families who are dealing with a serious illness or end of life, which is where hospice comes in, by providing choices, dignity, and compassionate care. And our goal all along has been to try and bring that same level of support and care and compassion in treating the whole person and promoting comfort to patients much earlier in their disease process, perhaps before they're ready for hospice, which is where palliative care comes in. Again, I've mentioned that palliative care is that whole person centered care, very much focusing on all symptoms. Like I said, that holistic approach, physical, emotional, spiritual, like that mind, body, spirit that you often hear, and really addressing that patient's comfort and quality of life. And ideally, what we're talking about when we talk about quality of life is, again, in alignment with the mission and the goals of the programs that many of you are offering, is, keeping people as comfortable as possible at home or wherever they may call home, whether that be an adult facility or a nursing home or wherever they call home, and ideally avoiding an unnecessary trip to the hospital. So the more we can support them in a home setting, the more we can hopefully impact their quality of life. Another big piece of palliative care, as you can imagine, involves empowering patients and their families. And a big piece of that is the education that we provide. Not only the emotional support, but the education and helping them to identify, well, what are their goals? What are they hoping for? What are they fearing the most? If they have, what are their goals of care? Helping them complete their advanced directives, maybe having those difficult conversations and advocating for them or preparing for them to have them with their providers in the community or other family members. Because let's face it, for many people who are facing or dealing with a serious illness or approaching end of life, they fear losing that control. So the more we can empower them with knowledge and choices, the more they can feel that they're maybe somewhat in control, or feeling that they have control over their situation a little bit more, at least. So again, our goal is, and this is what hospice is. Like I said, the difference between hospice and palliative care is sometimes confusing to folks, and I get that. Many people are starting to use them interchangeably, which makes sense in a way, because hospice is palliative care. All hospice patients receive a very robust, excellent palliative care. It's highly specialized palliative care for end of life, basically. Because once a patient comes on to hospice, their goals become comfort measures only. So that's what we do. We promote their comfort and quality of life. Again, our goal is to be able to provide that same level of support before someone maybe is ready for hospice or who's appropriate for hospice, but absolutely still needs palliative focused care. Just to recap for a second, the difference between, and what I mean by when somebody's maybe not ready for hospice or appropriate for hospice. Because in order for someone to be eligible for hospice care, many of you already know or associate hospice with end of life care. So according to Medicare, which is the governing body that regulates us and who pays for hospice care. Hospice is a very rich benefit under Medicare and Medicaid and most private insurances. But the criteria to be eligible for hospice under those plans is that they have to have a prognosis of 6 months or less, as long as the disease follows its natural or usual course, meaning no one really knows for sure. It's not an exact science. So it's really a matter of, would their provider be surprised if they were to pass in the next 6 months? And when we say natural course, it also means that at this point, they're no longer electing to choose to receive any treatments that are considered aggressive in nature or curative or disease directed, that any of the treatments that they're going to be receiving at this point are purely for comfort purposes only, for palliative purposes only. And again, you may have worked with people or know of people that they may look like they're approaching the end of their disease process. They might be end stage, but they're just not quite ready to give up treatments. The best example that you can think of in that case would be, say, somebody who may be dealing with or suffering or have cancer, and they're just not ready to give up the chemo, or different types of immunotherapies or disease directive therapies that are out there, or even somebody who's end stage renal disease and they're still on dialysis. Those measures are considered aggressive or tend to be more curative in nature. They may not be ready for hospice, but they absolutely could benefit from palliative care, because let's face it, sometimes the treatment can make them feel pretty sick. So they need that additional support in the home to help with managing those symptoms. Again, that could even be associated with the therapies. So this slide just kind of shows you the chronic disease on a continuum of care and sort of how palliative care fits into the disease process, from diagnosis throughout the stages up until death. That palliative care is appropriate for somebody, who might already have home care services in the home, but need an additional layer of support, maybe some nursing support, to help them with the symptom management piece. So the reason that we try to expand our reach and really try to help support patients much earlier in their disease process is because there's been lots of studies out there that have suggested that the sooner that we can start offering palliative care to folks, really the better the outcome, not only for the patient, but the family. I mean, think about it. If we can start working with family or patients and helping them feel better, the sooner they feel better, the less pain, the less symptoms, the greater satisfaction they have with their care. Some studies have suggested that not only they start to live better sooner or feel better sooner, live better sooner, sometimes they actually live a little bit longer. There's one famous study that was done that was published in the New England Journal of Medicine. It's called the Temmel study, that they compared patients who were dealing with breast cancer and patients who received palliative care while they were receiving their chemotherapy and radiation. Alongside of that, the palliative care alongside tended to live almost 3 months longer than those who did not receive palliative care. And so not only does the patient often have better outcomes the earlier we can introduce palliative care, so does the family. Again, as I mentioned earlier, a big part of what palliative care is education and advocacy. And that includes helping the families and the caregivers as well, helping them understand what the disease process entails. Is this normal? Is this what to expect? Here's what we can expect to happen next. That can be pretty empowering for caregivers. giving them the right tools that they need to care for their loved one. Knowledge is power. And they too have greater satisfaction with their care, and in the end tend to have better outcomes from a grief, healing, bereavement perspective. The challenge that we have currently is, I'm going to skip to the next slide, is that right now, I mentioned that Medicare and Medicaid and most private insurances have a very rich benefit and pay for hospice. Many programs, Medicare does not currently cover palliative care unless they're on hospice. So this is where we've had to get a little bit creative. And right now, Helios Care has two options for offering palliative care to folks who need it in the home setting. One is they can pay for these services privately, out of pocket. Sometimes we come across a private insurance that has a palliative benefit, not very often, but sometimes they might have perhaps a long-term care insurance, or the family might have the ability to pay for these services out of pocket. We do recognize that that's not ideal. We get lots of calls from folks in the community who are seeking palliative care. They need the extra support, but still can't afford to pay for those services out of pocket. So what we've had to do is find other creative ways to find funding to get to those folks. And fortunately, earlier this year in 2020, we were successful in obtaining a grant through a private foundation called Mother Cabrini. They're out of New York City. So they are funding palliative care services to folks who need it through a program that we're calling Choices. Again, we liked that name because it's a great way to offer another choice for another level of care to folks who need it in the home setting. There is eligibility criteria for this program, and I've listed that here. It's for patients who, the technical term is considered high utilizer. How we determine it, or how we define it, I should say, is somebody who's dealing with a serious or chronic disease who may have had at least 3 emergency department visits or 2 admissions in the last 6 months. The goal of this program specifically is to stabilize them. As I mentioned, to immediately go into the home, high touch interventions, addressing their symptom needs. How can we immediately address these needs and improve their care? Again, by offering that whole person approach, that interdisciplinary approach in the home setting, reducing unnecessary or avoidable trips to the emergency room, or avoiding an unnecessary hospitalization. And then ultimately transitioning them to a longer term, more appropriate program. In many cases, patients who come to us through palliative care who have been dealing with a serious illness or chronic disease have used the palliative care program as a bridge to hospice. So ultimately, many of these patients would ideally transition to hospice care when they're ready. So some of the services that are provided, again, with a focus on comfort and quality of life and keeping patients comfortable in the home, is our nurses go in and do the face-to-face visits in the home. The very first assessment is very comprehensive and is done by one of our palliative care nurse practitioners. Again, she is addressing the whole person, looking at not only how are they managing their symptoms and how can we help, but, how are they doing? Do they have enough caregiver support? How are they doing? What are their social determinants of health is, one of the key words that we use, or buzzwords that you often hear. So we're addressing all of those. she starts having those goals of care discussions, finding out what are their goals? What are they hoping for? What matters most to them? And starting the advanced directives process by completing their living will, their healthcare proxy forms, preparing for the MOLST conversation. Again, starting that care planning process right away so that we can make sure that we do have a plan in place to address all of those needs and the choices that the patient and family may make. We offer, our nurses under this program visit maybe once every couple of weeks, once a week if needed, but ideally they don't need us that frequently, but the good news is they know that we're there if they need us to call upon. We can offer those follow-up visits and support. We have found in other palliative care programs that we've been able to offer that the key piece to being able to avoid an unnecessary emergency room trip or to help these patients feel supported is being able to call upon us 24/7. So they do have access to our on-call support and our on-call team after hours. Along those same lines, we offer telehealth equipment. So each patient family gets an iPad that's linked to us. We can monitor them. They go in and take daily questionnaires, surveys. They can communicate with us. We can do video conferencing. It's just another way for us to monitor them and for them to communicate with us. A big piece of this, in addition to the RN support that they might get or the nursing support, is support from a social worker if needed. Again, a big piece of this, as I mentioned, is, the psychological drain, if there are many social determinants of health that are interfering with their quality of life, we can help with addressing those and linking them up to other resources that might be available to them in the community, which is how we get working so closely with Alicia and her teams and, the various Office for the Aging's offices or programs throughout our 3-county catchment area. I already mentioned the ongoing education that we provide. And we do those face-to-face reassessments that our nurse practitioner does upon admission every 60 days. We've been offering this program since last February. And we track the results in our data, and we have been able to positively influence their utilization. So not only have we been able to help avoid unnecessary trips to the emergency room, but through those comprehensive assessments that are done every 60 days, we have been able to identify that, again, we've been able to improve their quality of life. We're seeing, improvements in scores on their symptom management needs, the caregiver burden, patient engagement, their spiritual needs, all of those other things that we have assessed, we are seeing improvements when we do those follow-up visits every 60 days. So that's the good news. I always tell folks, whether you're on hospice or, or palliative care, we stay very close contact with your provider in the community. So they don't lose touch. They still have the relationship with their providers in the community, particularly with palliative care, because let's face it, they are still probably going to their doctor's appointments or going for treatments. So we just become an extension of their medical team in the community. I call we kind of become an extension of them, their eyes and ears in the home. For patients who might have a care team, like working with Kim or Kelly and Danielle, we would work very closely with their RN case manager in the community. Again, sometimes we can sort of see more when we're actually in the home and can see what might be impacting and can help collaborate with the teams, with their medical teams. And I already mentioned that social workers or psychosocial counselors are very heavily involved as well. We aren't able to provide the home health aid support through this Choices program. However, if we do have a patient, and we have quite a few that are paying for palliative care services with us privately or through a private insurance program, they can also get home health aid support. And they, just that additional support with providing the personal care, the bathing, the dressing, that type of stuff, activities of daily living. Again, ideally, sometimes these patients stabilize. With palliative care, we've seen patients come on and off. If they have an immediate need that we've been able to address, symptoms that have been well managed, we've been successful in linking them up to other resources that might be available to them in the community. We've met their immediate goals. We've had patients who've been discharged, or like I mentioned earlier, maybe they're transitioning into a longer term program, ideally hospice. Or sometimes patients we've been able to, been successful in, maybe getting them into a long-term care facility or an adult home where they've got more hands-on caregivers. So their goals have been met and they've been discharged from palliative care. We've had some patients that have been on for a long time too. It depends on the needs. So that's an overview of our palliative care in a nutshell. I would very much like to open it up to questions, comments. I can't see if there are any in the chat, but just before we go into questions, I just want to reiterate that, like hospice, anyone can make a referral to palliative care. We get so many calls directly from the community, from other agencies that might be working with these folks. Lots of times we get calls directly from family members, or sometimes even from the patients themselves. They know they need the additional help. They're struggling. They don't know where to turn. So they call us, and we're happy to walk them through and reach out to their providers in determining which one of our programs they might be most suitable for or eligible for. And like with Alicia or myself, even though we get referrals from different community members, we might refer people back to, the other agencies that exist in the community. Right. Which is why these programs are always so helpful for all of us to understand what it is we offer so that we can, make those connections for the people who might be reaching out to us.
There are no questions in the chat, so if anybody on the line has any questions, you can go ahead and unmute yourself and ask those.
Comments? Did you learn anything new? Did I meet my goal? Or was it just a repeat, maybe?
We have crickets on the line.
You do? Well, how about this? You have my phone number right there in front of you. That you can call any of us on the access team. If you'd like more information, we'd be happy to send it out to you. If you have somebody in mind that you're wondering about, feel free to call us, or just general questions. We're here to answer those. We always say it's never too soon to reach out, because even if somebody's not quite ready for palliative care or for hospice, by reaching out to us and getting the information you need, we feel that that's a great way, again, to empower folks, because even if they're not ready now, they'll know when they will be, and they'll have the information available.
All right, if there's no questions, then that will end our presentation for today.
Thank you all for participating.
Thank you very much for the presentation. It was great.
Okay. Thank you for for joining, and I look forward to furthering discussions with you, Kim and Kelly and Danielle. Thank you so much.
you.
Okay.
Thank you. Have a great afternoon and Happy New Year, everybody.
Happy New
Thank you.
Year.
You too.